thank you very much, especially the organizers. It's been a long time with no meetings, and I'm really excited to be here and see you all in person. So switching to something slightly different, I just wanted to say with pseudo-relapses and checking neurofilament, it serves two purposes. First, you can rule out there's a relapse. Second thing, you decrease the risk of other pseudo-relapses because patients generally, don't come back for another check. So these are my disclosures. Then looking at the pandemic, of course, we in Europe have fared pretty well. And interestingly, the UK and Sweden did about the same, I think, except that we didn't have the lockdowns and we don't do that much testing and we're late with the vaccines. But probably other things that cause these differences in different regions. Now with the vaccines, of course, that's where we pin our hopes, including Downing Street. You were promised not to have any more lockdowns, I heard yesterday. Who knows? So a little bit about COVID and DMTs, a little bit about COVID vaccines, but Emma told you all the background, and then turning a bit on COVID vaccines and DMTs, and then some practical examples, because I think it's very difficult from this aggregated data to really see the practical problems we see in the clinic. And then some known unknowns, to quote Donald Rumsfeld. We skipped the unknown unknowns for another occasion. So we all know or have seen these data from different cohorts, and they are pretty congruent. So anti-CD20 is not the best drug to be on if you get COVID. I think it's important to keep in mind, at the group level at least, with the French data showing how different covariates affect the risk. So disability over age, over obesity, and other comorbidities. So not all patients are at the same risk, even if they have the same treatment. It's difficult at the personal level to see really how the risk will turn out. Swedish data, since we have a very large proportion of patients on anti-CD20, so Jan Hillert just published a first study from the Swedish MS registry, confirming again that there was an increased risk with anti-CD20 for hospitalization. What's written there is that there is also a relation with the duration since last dose, but that doesn't really hold when you look at more long-term data. And in fact, in a study we just compiled on a very kind of well-characterized cohort called Combat MS, where we have dates for all doses ever given of anti-CD20. There is no statistical, at least, correlation with time since last infusion or accumulated dose. And here we just looked at anti-CD20 treated patients in rituximab. And out of 172 cases, then 26 were hospitalized, 5 came into the ICU, of which 4 had ventilation. But fortunately, no one died. But to make things a little bit more complex, this is a true patient that was not included in this analysis because she got COVID just after the cutoff date. And this is a patient that received the last dose, or the most recent dose of anti-CD20 in September 2018. We then stopped because she had recurrent herpes infections. Generally, and we've also published on that, we don't see that many herpes infections or zoster infections with anti-CD20, but she definitely had a problem here, so we took a drug holiday that we extended because her B cells were low. In February here, her B cells were not yet within the reference interval. She had the first dose of COVID vaccine and just a few days later got COVID, where she was recovered in another place in Sweden for a week, got discharged, which might not have been the best idea. and readmitted. She still had SARS-CoV-2 in blood. She was in the ICU, and really we didn't know if she would make it, but she did. And this is a young person. And just to say that dynamics, when we look at this, and we heard, for example, of ofatumumab, and we've seen ocrelizumab data, that mean values doesn't hold for all patients. So here, 3.5 years after last dose, her total B cells levels are below the reference level. And what you also see, because not all B cells are the same, she doesn't have any memory B cells or below detection limit. And this is also a common finding, that you see these transitional cells coming up. So repletion means it's more complex than just having your cells back. You also need to have the same distribution of cells. This could be also a good thing, because I think this relates to the efficacy of anti-CD20 over time. But it could be a bad thing when you're talking about vaccinations. So this was a study we did. We screened a large number of patients in the combat trial in our clinic, 620 of them, with a questionnaire just asking for different forms of infectious symptoms. We added a few patients with confirmed COVID, and this was the entire cohort. And then we selected those most likely to have had COVID, because we wanted, if you just test antibodies and if you're on anti-CD20, and we know that healthy subjects do not always seroconvert. So we had a smaller cohort where we checked also T cells or T cell reactivity to SARS-CoV. So here you can see the antibody level, and this is the amount of T cells reacting to SARS-CoV peptides. So most patients, even those on anti-CD20 group here, so they have both antibodies and T cells. Some only T cells, no antibodies, and some antibodies but not T cells. And of course here, it's very difficult. People get a bad COVID, you get a strong immune response. If you have very mild COVID, you won't get the same kind of triggering. So it's difficult to talk about qualitative differences. But just looking at anti-CD20, because I think this is of some importance when we talk about vaccination. So some people, or quite a few actually, of those with B cells below the detection limit develop antibodies after COVID, at least. But some here, those are the red ones with below detection limit, and here is also one with low B cells that didn't go over the cutoff. So when we talk about MS-DMTs and COVID, only anti-CD20 and not like sphingosine phosphatase inhibitors like fingolimod are associated with an increased risk of a severe disease course. And we have these covariates. Most people with anti-CD20 treatment and COVID nevertheless develops both antibodies and T cells, at least in our material. And given this fact, then vaccination should be really favorable for those of our patients on anti-CD20 compared to other patients. So what we can learn, or what we rather rapidly see with these vaccination campaigns, is first of all, they're effective. And they trigger both a humoral response with antibodies, but also T cells. So the question is, what are those? I mean, what is most important, antibodies or T cells? This, of course, is very difficult to address in human studies, but here is a recent non-human primate study where you can see how, in a dose-dependent way, if you give convalescent IgG from monkeys that had COVID to naive animals, they get to a variable degree protected from infection. So antibodies seem to protect from getting the infection. With T cells here, they depleted not all T cells, just the CD8 population of T cells. And it seems that those without T cells have higher levels of virus, arguing that T cells could be useful for controlling infections when you get it. Then about breakthrough, I mean, what we can get from human data. So this is an Israeli study where they looked at breakthrough infections in those vaccinated, and there seems to be a relation. Those getting a breakthrough infection had lower antibody titers compared to people not having infection. Of course, you would need a randomized controlled trial and really expose people to be really sure, but at least it indicates that antibodies are important for protection from infection. And this was mostly in pre-Delta variant, so likely we'll see more breakthrough infections with Delta. It's also difficult to compare clinical trials with real-world data. So with clinical data or clinical trial data, then antibody titers don't wane that fast, and they keep this virus neutralization capacity. But then we start to see data from some countries, such as Israel, where depending on when you were vaccinated, and I heard on the BBC yesterday it was a big debate whether to go for a third boost or not. I have a patient that works for let's say the Swedish CDC, and they think that there's market interest. Of course, Pfizer and Moderna are really, really happy. We're talking about booster vaccinations. So I think we don't really know yet if it's of value for the general population. And something I didn't know before, I thought, I mean, we generally say we give vaccination, then we talk about reintroducing a DMT. A couple of weeks afterwards, but what in fact is true is that this immune response continues to evolve over a month afterwards. And if you get a wild type infection, then it's up to a year here in a recent study. So what happens is that your memory B cells continue to evolve, and they start to be specific for slightly different epitopes. You get a greater bandwidth, possibly a better protection from variants. And what seems with vaccination is that you get really high, antibody titers, but they don't evolve to the same extent. So what is the effect when we give, let's say, anti-CD20 4 weeks after vaccination or COVID? We don't know that. We also start to see some degree of immune escape. It's not that evident if you look at clinical infection, because we hear that our vaccines protect from Delta, at least hospitalization and really severe disease. But when testing experimentally, then these are, the Pfizer vaccine and AstraZeneca vaccine, then there's a little bit lower, you can see here, for example, Delta, the neutralization rate compared to Alpha variant. So possibly we'll see new variants coming up where our protection goes down. So at least some individuals, this is also individuals, so some people will have an immune response that continues to protect, but at the group level we'll see more breakthrough infections. So when we think about our patients, then we've seen this already yesterday. I think Emma showed this. There's an increasing number of studies, and this is not the complete list, but some of the more important studies. So the study from Israel here, where anti-CD20 and also S1P blockers, they don't result in an antibody response in a great deal of patients, whereas cladribine or untreated patients look like healthy controls, or the controls here. There's two recent studies that look also at T cells. So one from Amit Barawar. So as predicted, there will be low numbers of memory B cells recognizing SARS-CoV, and those on anti-CD20. And you also get lower titers of spike-specific IgG. So this really confirms that anti-CD20 impairs humoral immunity. While if you look at T cells, it's a little bit complicated. The easy interpretation is that you don't see that much effect, but there, in fact, there is a little bit of kind of features. You get lower numbers of follicular helper T cells that are important to develop antibody responses, and instead you get higher numbers of spike-specific CD8 cells, and of course we don't know if that's a compensatory increase or not. But T cell responses are present, basically, or will be present in all people or patients vaccinated that are on anti-CD20. So we did a study on SARS-CoV or the COVID, but we were asked to add a little bit of data due to this weakness that we couldn't have a standardized immune stimuli. So we added a small cohort here, and we're doing a bigger cohort now where we check. This is called fluorospot, where you seed T cells or immune cells or T cells, and then you stimulate them here with medium, the nucleocapsid protein. And here, the bright spots here are reactive T cells that express interferon gamma. So with vaccination, you don't expect to see nucleocapsid protein-specific cells. And in fact, this is what we saw in the patients. So no T cells evolving recognizing the nucleocapsid protein, whereas you see rather good levels of spike domain-specific T cells. What was a little bit interesting here is that there's some patients with very low B cells, and we selected here a representative value of people with very short or long-term since last dose to get an idea of the kind of gradient or the spectrum here. So some people with very low B cells anyway convert to seropositive status, and some do not. So based on this and other data, one could say that most individuals with detectable B cells will develop an antibody response, whereas only some individuals with undetectable B cells would do that. So looking at B cells could, it actually predicts if you will make antibodies or not. But even if you don't have B cells, you may do it. And all then developed T cells. So what we do here with our drugs, with anti-CD20, of course, we kill off this arm, the humoral arm of the immune system. So we don't have any B cells, we don't get any plasma cells, we get T cells. It's a bit more complicated with fingolimod, for example, because we don't actually kill the cells, we just make them kind of disappear from the blood compartment, and we don't know how this will impact on T cell reactivity. It's kind of tricky. When we look at these T cell assays, for example, we need cells. So if you sample cells from someone on fingolimod, you need to take much more blood to do the same analysis. So it's tricky to know if these cells hide somewhere else in the lymph node, for example. But potentially with fingolimod, you will affect also the T cell side, not only the B cell side. And it's a little bit surprising, in fact, that there's so few that develop antibodies in the Israeli study. In our experience, more than half on those on fingolimod develop antibodies. But a huge spectrum, some very high levels and some below detection limit. So some practical examples now how to think. And these are just thoughts, just I wanted to something to discuss. So this is a person on anti-CD20, a woman, regular infusion here. She is part of a clinical trial, a little bit longer here to allow a little bit more time for vaccinations. But still B cells below detection limit here, and no antibodies. So the question is, should we revaccinate? Depends on what we think here. If we want an antibody response, we shouldn't really give the vaccination now. She doesn't have any B cells. It's very likely she will not develop antibodies, while we're pretty sure she will have T cells. We don't know if this third booster for her T cells will do any good. So perhaps better wait a while. This is a person, a woman with more long-standing disease, a bit higher disability. regular infusions here. And then we started to delay a bit, and here was a long delay due to the pandemic and perceived benefit risk with continued treatment. She got the treatment here at the end of last year, and about 5 months later she got vaccinated, and she has higher antibody levels than I do. She had B cells after 6 months, so that's also kind of as expected. Then probably there's no hurry to give a booster to this person. This is an example of a person, a man this time, that started anti-CD20 rather recently, totally depleted the B cells here, got vaccinated here, and pretty high levels of antibodies, about my levels, in spite of B cells under the detection limit. Interesting. So the question here, whether to boost or not, maybe not that hurry again. This is, I think, the record, at least in my experience. This is a person with myasthenia gravis that had the last dose in August, 4 years ago. Still B cells below detection limit. Had 2 doses of AstraZeneca, no antibodies, and this is a high-risk person. A man about 80 years of age. So probably here is a very good idea anyway to try to boost, but then perhaps change to an mRNA-based vaccine, although we have limited evidence of how more effective that could be, but there's some evidence. This is a person on fingolimod, woman, and she got vaccinated in April, May. Also really good antibody response over the upper limit, more than me. And this is, well, not maybe that a hurry to give a booster, but perhaps, I don't know. She has her T cells we don't know about. So I would, here's a little bit of difficulty, because with fingolimod or S1P, we don't really know if they worsen the disease course or not. But maybe it's safest to suggest a booster in any way. This particular patient was a little bit different also, I forgot to say that, or I don't know if this has anything to do with this, but last year she started to have increased liver enzymes, and we did a series of examinations, couldn't find a cause, and then we gave her 5 pills a week instead of 7, and her liver enzymes went down, and we continued that way. I was asking David, who knows this much better than me, that I think it's a stupid idea to, or he thought it was a stupid idea to stop giving drug. In that case, at least with fingolimod, with a very long half-life, if you really want an antibody response, you could consider giving fewer pills a week. But probably you need to wait a long while, or several weeks or months, until you get to steady state. So to conclude from this, current vaccines are safe and effective with most DMTs. We will see a blunted humoral and intact T cell response with anti-CD20s. But even among those with low B cells, it's worthwhile to vaccinate, but perhaps consider twice if you should give a third booster if they're still below detection limit. At least if they have been giving a new dose since the first 2 vaccinations. And then perhaps it's better to delay the third dose. And there's really large individual differences in the repopulation statistics or dynamics. We're trying to compile that data from a pretty large cohort of about 700 patients now, with variable extensions of dosing intervals. And in some patients you may need up to a year. With S1Ps, we don't know the effect on the T cell response, but it's kind of reassuring that we don't see a strong clinical signal for worsened disease course. We don't know the effect of a third booster dose, but I think for this patient group we should consider that. And again, if you really, this is with 3 question marks, consider reducing the weekly dose for a while if you really want to see an antibody response, and maybe do a study. The known unknowns, I think with epidemiology, we need to do better refinement of the risk profiles, the predictors for the adverse outcomes, so we can inform our patients. And with immunology, I think now we should follow the immunology over time to see really what happens with repeated doses of anti-CD20, for example, after. It could be also cladribine or alemtuzumab after the vaccinations, to see how that affects the immune response and also potentially the clinical efficacy. So if we have an immune response, we have plasma cells, we also have memory B cells, and with new anti-CD20 will deplete these ones. And with certain vaccines, this is an example here for hepatitis or Haemophilus influenza. With hepatitis, with a rather long incubation period, these memory B cells are really important because if you're exposed to virus, they will start to differentiate and become plasma cells and produce much more antibody, and they will protect you from infection. With Haemophilus, it's a little bit different. Looks more like COVID. It's a short incubation time, so here low levels of antibodies will not protect you in the same way. So some acknowledgement, and I'm happy to discuss here. I think many of you are sitting with the same problems.